Hello dear viewers, in this video which is part 8 of continuous renal replacement therapy, I will be discussing part 2 of regional citrate anticoagulation where I will discuss about citrate and calcium infusions. I will discuss briefly about citrate metabolism as well and how to adjust initial flow and subsequent adjustment of citrate and calcium infusions so CRRT therapy can be executed safely and effectively. How citrate works as an anticoagulant. When citrate is infused into the blood, it rapidly chelates the ionized calcium in the blood to form citrate calcium complex, thus reducing the level of ionized calcium in the blood. Ionized calcium, also called coagulation factor 4, is vital for multiple steps of coagulation process. Under physiological conditions, the concentration of serum ionized calcium is 1 to 1.2 millimole per liter. Blood coagulation will not occur if the blood level of ionized calcium is reduced to below 0.35 to 0.4 millimole per liter. Due to different CRRT modes and therapeutic dosage, about 30 to 60% of the citrate calcium complex molecules will enter the effluent through the permeable membrane. The citrate calcium complex, which are not removed via the hemofilter, enter the systemic circulation and are first metabolized rapidly into citric acid in body cells. As a result, severe hypocalcemia can occur if ongoing supplementation of ionized calcium is not provided. Therefore, adequate amount of ionized calcium must be supplied directly to the patient intravenously or through the return end of extracorporeal circulation circuit to maintain physiological ionized calcium level. RCA anticoagulation is thus achieved only in the CRRT circuit. This is the reason it is called regional anticoagulation with little interference with in vivo coagulation process. This is a schematic diagram of citrate metabolism. When citrate is infused into the extracorporeal circulation, citrate calcium complex is formed and ionized calcium is rapidly reduced to prevent clotting. About 30 to 60% of citrate calcium complex enter the effluent through the permeable membrane depending on different continuous renal replacement therapy modes and therapeutic dosage. The residual citrate calcium complex return to the systemic circulation and are metabolized rapidly in body cells. The half-life of molecules under physiological condition is only 5 minutes. The molecule is eventually decomposed into bicarbonate through the tricarboxylic acid oxidation cycle. One molecule of citrate yields 3 molecules of bicarbonate and the ionized calcium is released back into the blood. Currently, there are two forms of citrate solutions available for anticoagulation. One is only used as an anticoagulant known as citrate anticoagulant. It includes 4% trisodium citrate and acid citrate dextrose formula A. Trisodium citrate solution is more commonly used than acid citrate dextrose. Both are hypertonic solutions. Here you can see sodium and citrate content of both solution. For trisodium citrates, sodium content is 420 millimole and citrate content is 136 millimole. The similar value for acid citrate dextrose formula is 224 millimole for sodium and 113 millimole for citrate. The other form of solution is a kind of buffer solution containing citrate. These are balanced isotonic solution which can be used for anticoagulation and as a pre-dilution replacement fluid known as citrate replacement solution. Currently, there are mainly manual citrate based replacement solutions and commercial solutions. Prismocitrate is a commercial solution. Remember, citrate based replacement solution cannot be used for post dilution or dialysis. How to set citrate dose during regional anticoagulation? It is recommended to set initial citrate dose based on blood flow rate, and the citrate dose should be appropriately adjusted subsequently according to the monitoring value of filter ionized calcium. The recommended target value of ionized calcium in the filter is 0.2 to 0.4 millimole per liter, but the target value should be individually adjusted according to the treatment situation. Citrate is added at the excess end of the extracorporeal circuit to ensure a citrate concentration of 3 to 4 millimole per liter in the circuit. To supplement the calcium lost in the effluent through the filter membrane, extra ionized calcium is infused in the return end of extracorporeal circuit or directly to patient via central vein to ensure normal serum calcium in the patient. It is very important to monitor the concentration of ionized calcium in the patient's systemic circulation sampled from the patient's artery or vein or from excess end of extracorporeal circuit. If calcium-free replacement fluid is used during CRRT, the initial flow rate of citrate solution depends on anticoagulant used. For acid citrate dextrose solution, it should be blood flow rate in ml per minute multiplied by 1.8, and for 4% trisodium citrate solution rate in ml per hour, the blood flow is multiplied with a factor of 1.5. If replacement fluid containing calcium is used and pre-dilution CVVH or CVVHD mode is chosen, the flow rate of citrate solution should be increased to chelate ionized calcium in the replacement fluid. The initial flow rate is empirically suggested to be as follows. If acid citrate dextrose solution is used, then rate in ml per hour will be blood flow rate in ml per minute is multiplied to a factor of 2, while in case of 4% trisodium citrate solution, blood flow rate is multiplied with 1.7. Remember, these are initial citrate flow rate only, and subsequent adjustment should be made based on ionized calcium levels in filter. To understand the relationship between citrate dose and blood flow, have a look on this table. Assume blood flow is 150 ml per minute, so the total flow of blood in 1 hour will be 150 multiplied by 60 equal to 9 liter per hour. As I discussed earlier that the citrate concentration in blood should be between 3 to 4 millimole per liter. Assume if we decide to keep citrate concentration at 3 millimole per liter, then the required amount of citrate for the 9 liter of blood flow will be 3 multiplied by 9, and it will be equal to 27 millimole of citrate per hour. As I discussed, the citrate concentration in the 3% ACD solution and 4% TSC solution is 113 millimole per liter and 136 millimole per liter respectively. So, how much 3% ACD solution will be required to achieve 3 millimole per liter of citrate concentration? It is 27 divided by 113, and it will be around 240 ml per hour. Similarly, for 4% TSC solution, the required flow per hour will be 27 divided by 136, and the resultant value will be around 200 ml per hour. Similarly, we can calculate the dose of citrate anticoagulant if the target concentration of citrate is more than 3 millimole per liter by the same method. To achieve the ideal anticoagulant strength, the ratio of 3% ACD solution to blood flow is about 1.6 to 2.13. The ratio of 4% TSC solution to blood flow is about 1.33 to 1.73. The lower value indicate target citrate concentration of 3 millimole per liter, while upper value indicates target citrate concentration of 4 millimole per liter. For the ease of understanding, if blood flow is 200 ml per minute and the anticoagulant used is 4% trisodium citrate and target citrate concentration is 3 millimole per liter, then the 4% trisodium citrate flow rate will be 200 multiplied by 1.33 means around 265 ml per hour. Once CRRT therapy is initiated with empirical citrate dose as discussed, subsequent adjustment of citrate dose is based on monitoring of filter ionized calcium level. Monitoring of ionized calcium is done with blood gas analyzer and it is recommended to make first measurement as early as 30 minutes. Then monitor it every 2 hours for 4 consecutive times. If the dose of citrate remains stable and ionized calcium is within range and anticoagulation is appropriate, monitoring interval can be increased to every 4 hours. How to adjust citrate dose based on target ionized calcium level can be understood by this table. Largely, if value of ionized calcium is below 0.2 millimole per liter, the dose of citrate anticoagulant should be reduced, and in case of value more than 0.4 millimole per liter, the dose of citrate anticoagulant should be increased. Calcium supplementation is done to prevent hypocalcemia as calcium is lost as citrate calcium complex through semi-permeable membrane. It can be administered through the return end of extracorporeal circulation circuit or directly through the central vein. 5% calcium chloride and 10% calcium gluconate are commonly used for ionized calcium supplementation, and the difference in ionized calcium concentration between them is about 1.5 times. The ionized calcium concentration in 5% calcium chloride solution is about 1.5 times that of the 10% calcium gluconate, while 5% calcium chloride contains 340 millimole per liter of ionized calcium, 10% calcium gluconate has 224 millimole per liter. If calcium-free replacement fluid is used, it is recommended that the initial flow of 5% calcium chloride infusion be set to an effluent flow rate divided by 200, or 10% calcium gluconate infusion be set to an effluent flow rate divided by 125. But if a calcium containing replacement fluid is used and pre-dilution CVVH or CVVHD mode is selected, an initial flow of 5 ml per hour for 5% calcium chloride infusion or 8 ml per hour for 10% calcium gluconate infusion is recommended. It is recommended to adjust the calcium supplementation rate according to the monitoring in vivo value of ionized calcium. The recommended target of in vivo value of ionized calcium is 0.9 to 1.1 millimole per liter. The sample for in vivo ionized calcium monitoring should be obtained either from the patient or from the access end of extracorporeal circulation circuit prior to the site of citrate addition. It should be emphasized that the just discussed calcium supplementation rates are empirical only and used for making initial setting, and the subsequent calcium supplement rate must be further adjusted according to the level of in vivo ionized calcium. It is suggested to monitor the in vivo ionized calcium level according to the previously stated plan as we discussed for monitoring filter ionized calcium value. Initially after 30 minutes and then every 2 hours for 4 consecutive times. Adjust the calcium supplementation based on target in vivo ionized calcium level of 0.9 to 1.1 millimole per liter. This table provides a guidance to calcium supplementation adjustment. Here I finish. If you have any questions, please write them down in comment section. See you in my next video on CRRT part 9 and regional citrate anticoagulation part 3. Till then, bye and take care.